There are special considerations for examining a horse compared to examining a small animal patient inside a clinic. Obviously, many times we're going to be out in the field as we are today, and so there are some things that you need to take into consideration. In addition, horses are big, powerful animals, and if they have a painful eye, safety to the handler and safety to the examiner is all important. So the first thing is, if we're going to be examining the internal structures of the eye, or even looking at the cornea, we need to have a minimum of external light. Now, in this video, we will have many staged procedures here where we do have lights on that normally we would have the lights off, so that the person watching this video can understand what we're actually doing. But in the field, having the patient in a darkened stall is optimal. Some people will improvise if they are literally out in a field and use a cape that would be draped over the patient and over the examiner at the same time. This is a little less than optimal, but sometimes this is what we have to do. You need to have a nice quiet area. Horses are easily distracted. They're big, powerful animals. If they start weaving their head back and forth, it makes it hard for you to follow the patient and see what you need to see. It's not like in small animals where you can just kind of hold them still. So having a nice quiet area where there's not a lot of other noise, other horses rattling around, buckets rattling, etc., is always an advantage. In addition, having a good handler, someone that knows horses. Morgan is going to be helping us with Ella today to manipulate the head, turn the head side to side, up, down, and just generally keep the horse concentrating on her instead of what I'm trying to do to examine the patient is very, very, very important. Use of twitches, whether it's an ear twitch, a skin twitch, or a nose twitch or something like that, is indicated only if the patient needs it. Many times if the horse is painful, you do have to distract them with a lip twitch or whatever, and once again, having a good assistant is all important in being able to do this. Now let's talk a little bit about sedation. Once again, painful-eyed horses are going to be difficult to restrain and difficult to do what you need to do. And so for the safety of the handler, safety of the examiner, and safety of the patient, sometimes we have to resort to chemical restraint. And so the two most commonly used chemical restraints, and the ones that I tend to use, are xylazine and ditomidine. These are both alpha-2 agonists. The dose that I like for xylazine is 0.5 milligram to 1 milligram per kilogram of body weight. For ditomidine, 0.01 to 0.02 milligrams per kilogram. These are both given intravenously. Xylazine gives you about 20 minutes of a good still head. They give you muscle relaxation as well as analgesia. Both of these drugs do that. Okay, but after about 20 minutes, even though the patient is still somewhat sedate, we get sort of a head bob phenomenon. So if you're actually trying to do a procedure like place a lavage system or something else where you're manipulating and you need a really still head, just take into consideration that you only have about 20 minutes. Now, ditomidine lasts longer. Most of the time I can get a good 40 minutes out of a single intravenous dose of ditomidine at the dosage that I just listed. Some people like to top these off with an opioid, and the most commonly used opioid is butorphanol. Butorphanol at a dose of 0.01 to 0.02 milligrams per kilogram will enhance the alpha-2 agonists. The problem that I don't like with butorphanol is the butorphanol tends to have a lot of head bobbing. So when I'm doing restraint to do some sort of manipulation around the eye, I'm trying to slice a piece of cornea off for a keratectomy specimen or whatever, I really don't want to have that head bobbing, and so I usually do not use butorphanol. A lot of people like acepromazine as a sedative. Acepromazine does nothing to control the head movement. The horse can be totally sedated and they're still weaving their head all around. So for most ophthalmologists, acepromazine is not a really effective drug. And then lastly, very important thing is to be able to open the eyelids. In a very painful horse, their orbicularis muscles are extremely strong, and you basically cannot overpower them. You will not see what you're going to need to see. So, and then in addition, if you had a fragile eye, say a lacerated eye or an eye with a deep corneal ulcer, the last thing you'd want to be doing is putting a lot of pressure on the globe and potentially causing the globe to rupture. So what we're going to do is we're going to show later here how to do a palpebral nerve block. The palpebral nerve originates at the base of the ear, runs down the zygomatic arch, and then splits and goes to the orbicularis muscles of the upper lid and the lower lid. And this is what allows the horse to squint or blink actively. Once that is in place, the animal can still move their eye, and they can passively raise and lower their upper lid, and they can still pull their eye back in the socket, which causes the third eyelid to go across. But at least you can open the lids so you can do things like tonometry or a better examination without having to worry about the patient constantly squinting or blinking because of they're either painful or they're resistant to the fact that you're shining a bright light into their eyes.